Thank you, everyone. I'll start with the talk. I'll be covering in around 15 to 20 minutes anaplastic large cell lymphoma. It's going to be a difficult talk after all these wonderful CAR T cell therapy sessions, but this has, I promise, no mention of CAR at all. So this is the overview of my talk. I have just divided into how it usually exists in review articles and in textbooks. So it'll be a little bit more of that. So we have mature T cell neoplasms, which are relatively rare compared to the B counterparts, and they present in four ways: leukemic, nodal, extranodal, and cutaneous. We've already covered by more prolific presenters. We've had a talk also on cutaneous lymphomas. And anaplastic large cell lymphoma has a presentation in each of the subtypes. So it can rarely, very rarely be leukemic, especially in the pediatric age group. Certain small cell variants of the ALK positive ones can present, but predominantly it's nodal, and there are a few extranodal and cutaneous forms which are rare. So most of the talk will be on the nodal ones, which are further subdivided into the ALK positive and ALK negative, which has also been spoken about. So coming to a brief history, from 1985, when this lymphoma was first identified by Stein et al. Then subsequently in 1989, I think that's getting cut out, the cutaneous form was identified. And in 1994, the real classification for the first time used the word anaplastic large cell lymphoma. And also in the same year, the translocation in the ALK gene was identified. So then in 1997, a breast implant associated disease was again recognized. And in 2001 and subsequently in 2008 classifications, they were separately, separated out into different entities. And as recently as 2018, we've got the approval for frontline use of brentuximab for the anaplastic large cell lymphoma, the systemic variant. So coming to the subtypes, which you already discussed. So primary systemic anaplastic lymphoma will be of two subtypes, predominantly based on the ALK expression in the tumor. You have an ALK positive and an ALK negative subtype, which is further subdivided based on the rearrangement in either the DUSP22 or the TP63 genes. And that constitutes around 30% and 8%. So the rest of them are known as triple negative. And the second subtype is the cutaneous subtype, which basically is restricted, and you have to rule out a systemic disease before labeling it as a primary cutaneous large cell lymphoma. This is also ALK negative and has frequent MUM1 rearrangements. And the most recently described one, which has close to 900 cases in literature now, is the breast implant associated subtype, which is also ALK negative. And each of these diseases are actually separate entities as per the WHO, because they have a different pathogenesis. So we'll come to that now, and the epidemiology basically. So it's the ALK positive ones are predominantly more often seen in the pediatric age group. So as a whole, systemic ALCLs are 20% of the pediatric NHLs, but are quite rare in the adult population. If you have an adult with a systemic ALCL, he's more likely to have a ALK negative disease. The median ages are presented here. You have 30 years for the ALK positive. And more than the genetics, also the reason why these diseases do well is also because of the age. So an ALK positive presenting after 40 years or 50 years has been shown, and there is data which shows that they don't do as well as the ones who are younger. So it's a function of both the age as well as the genetics of the disease. And primary cutaneous ALCL has also got a presentation similar to the ALK negative subtype. And as with all lymphomas, it's much more common in males. If ALK positive, then the younger males are usually predominantly your patient would be a male. The prevalence is it's thankfully quite rare. It's 1 in 100,000, and no viral etiology has been identified. This is not EBV related, not HTLV, and it's also not a age-defining malignancy. So the take home from this slide is just that there is only one significant difference, that is the age group that differs. The rate of stage 3-4 disease, the rates of elevated LDH, extranodal presentations, B symptoms, they're usually similar between the two subtypes of systemic large cell lymphomas. But again, very important point, the younger age group makes it a better outcome for the ALK positive ones. So I'll just briefly touch upon the pathogenesis. The ALK positive disease has a characteristic translocation, which has been spoken about in the morning session, between the chromosomes 2 and chromosome 5. So the ALK gene on chromosome 2 and the NPM1 gene on chromosome 5, the fusion creates the ALK NPM1 chimeric fusion protein, which produces, activation of downstream signaling pathways. And those are the pro-survival pathways that we typically study, the RAS, MAPK pathway, and also the JAK signaling. So that's JAK3 and STAT3 signaling. which leads to the lymphomagenesis basically. So it's the fusion protein which is driving the lymphoma. Then we have the ALK negative. The first subtype of that is the DUSP22 rearranged. DUSP stands for dual specificity phosphatase number 22. So this also differs from the TP63 mutated ones, the TP63 rearranged ALK negative disease. So the difference is that when you have a DUSP rearranged lesion, it reduces the phosphatase activity and also leads to a downregulation of PDL1. And there is also downregulation of the cytotoxic antigens, which is also seen when we do the immunohistochemistry on these specimens. And this leads to enhanced immunogenicity of the tumor. This basically explains why these diseases behave almost at par with your ALK positive diseases. So these are the two favorable subgroups, so to say. And this also is associated with a characteristic translocation, which is translocation between chromosome 6 and 7. So the third subtype of the systemic disease is the non-DUSP rearranged. And as we know, there is no DUSP rearrangement and there is no translocation. How does it work? There are mutations which are seen in the JAK1 and the STAT3. Similarly, obviously, it leads to an phosphorylation and a constitutive activation of STAT3, and which further leads to the lymphomagenesis, basically. Is completely different for a breast implant associated large cell lymphoma. This was typically noted in patients who underwent breast implants for either cosmesis or other purposes, and it's more commonly noted with textured breast implants. So now basically in the US, textured breast implants have been taken out. The smooth surface implants have been shown to be much less associated with it. The concept was that there was a chronic antigenic stimulation and also in a predisposed host. So it's just not the antigenic stimulation that's going to happen in all, but in a predisposed host that leads to a sequential increase from a polyclonal to a monoclonal proliferation and successively leading to a breast implant associated ALCL. So this is just a brief pathogenesis, and it has been shown that again this disease is also associated with the JAK-STAT signaling, and IL-6 is the driving cytokine. But when I looked up, anti-IL-6 or anti-IL-6 receptor therapies have actually got negative data in this space. So it's something which intrigues me. So the pathology, it's important that these diseases are typically nodal. So we're talking about currently the systemic forms of the disease. So they have two types of presentation, and pathologically, I mean. So that the classical one and the atypical presentations. So when you speak of classical, that's the bulk of the disease, right? So most of these cells, they invade the lymph nodes, and they have predominantly sinusoidal infiltration. So as the pathologist would know, obviously sinusoidal infiltration also happens in, when the carcinoma invades the lymph node. That remains an important differential sometimes, but we'll come to that later. So the classical ones, they form cohesive sheets. And sheets of what? Sheets of large cells. So the cell is large, the nucleus is horseshoe shaped, and it's placed eccentrically in the cell. There is some amount of paranuclear clearing. There's a prominent nucleoli, and there is abundant cytoplasm. So this is like how a typical cell looks. And we have some atypical variants, the small cell variant being the most common, and the small cell is seen in small children. So these atypical ones are usually more common in kids. The adults, usually when we see them, they usually would have a classical presentation with these type of cells. So this is one of the lymph node biopsies, which shows that there is relative preservation of the architecture of the node, but there is predominant intrasinusoidal infiltration by these cells. Just zoomed them in here, and this is further zoomed in, and we can see the morphology of the cell here. The cells are quite large, and they have folded multi-lobe nuclei. There's some Golgi zone accentuation that is appreciated by the, you can see the arrow marks. This is like the typical picture that one would find with folded multi-lobe nuclei, and again, having some Golgi zone accentuation at 400x. So this is a different one. This is again a cell which is large, but it doesn't look like the cells which we have seen previously here. So this is something, and it's to the extreme right of the image here. It shows that it looks like a donut, and that is when there is the ALCL cell which shows some nuclear pseudo inclusions. So they are predominantly seen in patients who have a DUSP22 rearranged systemic disease. Very rarely, these diseases, as I said in the first slide, can have a leukemic presentation. Again, the small cell phenotype sometimes can have this, but predominantly they are more commonly seen in ALK negative. Again, very, very rare. I think it's less than 1 to 5% risk of having a leukemic presentation. So coming to the IHC, which is the most important way in which we can establish a diagnosis. Obviously, the diagnosis for a nodal disease is always the best specimen is as big a specimen as is possible. So an excision lymph node biopsy and the morphology, as has been already just spoken about, supplanted by this IHC. So it's very important to remember that all of these anaplastic large cell lymphomas, CD30 expression is sine qua non. You'll always have strong and diffuse positivity, and that differentiates it from Hodgkin's. There are other ways to differentiate as well. These tumors will very rarely be PAX5 positive and also won't have other B cell markers. But again, 15 negativity and PAX5 negativity stay important in distinguishing it. And you will have ALK expression here, which is really important because very few tumors would express ALK in the hematopoietic system, I believe. So when we have an ALK negative, how do we do that? So nothing else changes. You just have CD30 as strong as it would be in the ALK positive, but just the ALK becomes negative. And around 30 to 40% of these tumors, be it ALK positive or ALK negative, can have sometimes a null cell type of phenotype. So then how do we diagnose them? They won't express any T cell markers. That is what it means by a null cell type, right? So then you have to look for a clonal TCR rearrangement. So that's around 30 to 40% of the cases. And those are the ones which lead to a diagnostic difficulty. But the ones which express T cell antigens, CD30 bright positivity, ALK positivity, then you are just straightforward looking at a large cell lymphoma. So what are the typical clinical features that we have in these diseases? Like with any lymphoma, there's lymphadenopathy, which is usually extensive. These diseases, because they are aggressive lymphomas like the B cell subtype, they usually don't present with early stage disease, the aggressive ones. So diseases on both sides of the diaphragm, stage 3, stage 4 disease. 20% of patients would have some sort of bone marrow involvement. Predominantly, they do present with B symptoms. We saw it in the first slide, a couple of slides, around 30 to 40% patients will have B symptoms. I believe it's much more in clinical practice. And extranodal disease is also really common. And as we said, bone marrow involvement in close to 1/5 of patients and skin involvement as well. So when you label someone as having a cutaneous ALCL, it's very important to rule out a systemic disease. Like it is important to rule out a systemic disease in primary before labeling it primary CNS lymphoma. So similar to on those lines. So what are the differential diagnoses? We did cover it a little bit in brief in just like 2 minutes back. So metastatic carcinoma pops in here. That's because, because of the sinusoidal infiltration. Easy to distinguish if you have a history and also, you don't know whether if there is a primary or not, but cytokeratin can help. And also the strong and CD30 positivity helps to distinguish it from Hodgkin's. So it'll also be CD30 positive, but the positivity is much strong and much diffuse here. And also ALK positivity and the absence of PAX5 in most of the times in ALK in ALCL. I mean, rarely can they can be ALK positive, but most of the times you would call it an ALK negative disease. Then here we've got a similar thing. ALK positive DLBCL is another entity which is usually like presents with a plasmablastic morphology. So that's usually CD38 positive, but it's really not going to be very difficult because of the CD30 that aids us. So ALK positive DLBCL is almost never going to be CD30 positive. So how do we prognosticate? Now we know what the disease is doing, how it presents. It's very important, and it's a three-pronged approach. There are some clinical features, some genetic features. Like we said, in IPI, the age is the most important factor of the IPI, which helps to distinguish it. And also, the proliferation and what the patient is going to have. So this was survival curves based on the age, and you can significantly see, you can see down the lines are significantly separating out. Once the age goes more than 40, then nothing else matters. The outcome is going to become significantly worse because of, the inability to give chemo a lot of times. And these are again, published in an era when brentuximab was not yet approved frontline. So this is all the pre-echelon 2 data. Again, genetic subtypes. So this is just reiterating what I spoke in that slide with the 3 curves. Here you see DUSP22 and ALK almost overlap each other. So they have really similar outcomes. So, but since they have a different pathogenesis, they have been subgrouped separately. And the 3 dots are the 3 triple negative disease, that is ALK, DUSP22 and TP63 negative. And that has an intermediate survival, which is also not so good actually. But the worst of the lot is the TP63. That's the TP53 homologue, and that's equally bad. So this is just putting the figure into numbers. When we have an ALK positive disease, we are fairly certain that the patient is going to do well. The 5-year overall survival is close to 70 to 80%, which is also similar for the DUSP22 rearranged disease. So those two have similar outcomes, but dismal outcomes as we see for the TP63 and also for the triple negative phenotype. Again, primary cutaneous disease, breast implant associated lesions are usually really good, and they have close to 80 to 100% 5-year survival. So how do we treat? The treatment is, has changed recently. So I think we should, speak a little bit more about brentuximab. Already it's been spoken a lot. But before we treat, we need to evaluate. We need to give the right patient the right therapy and the right amount of therapy. So ALK status will obviously determine a lot of things beyond prognosis as well. Suppose the patient relapses, there are therapeutic implications as well of knowing it. And the good thing is that the detection of ALK on immunohistochemistry correlates 100% with the presence of the translocation 2,5. So once you have a ALK on the IHC, you really don't need the genetic information. So you don't really bother with the translocation 2,5. And the IPI, as for any other lymphoma, is really important. But again, the age component of the IPI has a lot of significance. Most of these patients will be stage 3, stage 4, will have extranodal disease, bone marrow involvement. So they will have IPI more than 2 or 3 most of the times. But the ALK and the age are significant determinants, as we've already determined. So what are the treatment options? So this was, if we speak about brentuximab, it's not going to be available for everyone in this country, even today, even if it is launched. So we still stuck with the CHOP etoposide kind of regimens, infusional regimens also, DA epoch, obviously without DR. And again, the rest of the inhibitors, rest of the drugs which I've shown here in black are predominantly, more in the second line and the refractory setting for the non-transplant ones. For anyone who's a transplant candidate, basically, you will think of chemotherapy-based approaches followed by an autologous transplant for, maybe a refractory disease or even upfront in a few scenarios here. So when do you go for CHOP? When do you go for CHOP with etoposide? And how do you decide to etoposide or not to etoposide? So again, old data, pre-echelon 2. So when you're deciding between CHOP and CHOP etoposide, it's important to remember that the addition of etoposide doesn't mean that there's going to be an OS benefit. It's at best a EFS benefit. The etoposide improves the EFS, also not in all patients. It's got a major benefit, especially if the age is less than 60 and patients with an ALK positive disease or, a low LDH. So these are the subgroups when you should be thinking about adding etoposide in a young fit patient with an ALK positive disease maybe, and that too just expect an event-free survival benefit, not an overall survival benefit. So to irradiate or not, I mean, since morning we've been speaking about this. So obviously the question of irradiation arises in a localized disease rather than a systemic disease when chemotherapy is going to be an option. Again, you're irradiating bulk, not irradiating bulk, no clear data. It's a very rare disease out of the T-cell lymphomas, which is anyways, the zebras of the NHLs. But again, in early stage TNHL also, there was no difference in this study between the event-free and the overall survival with the addition of radiotherapy. So again, to use it, not to use it, again, this was not a very power. It was not powered enough to access for the ALCL. Most of these studies, ALCL was a subgroup analysis. It's not an isolated study, including only anaplastic large cell lymphomas. This combined all the PTCL NOS as well. So now the third question, to transplant or not. This is just like a summary slide. So if it's ALK positive disease, the threshold to transplant has to be really, I got to be really convinced to transplant because the outcomes are so good, especially now with the brentuximab approach. So I would transplant in CR1 if, the patient is old and has a high risk disease in the form of an IPI more than 3. So both of these probably would, trigger a transplant, but no ASCT if the patient is young or has a, IPI score less than 3. And in an ALK negative disease, I'll be more keen towards transplanting in CR1 because the outcomes are not so good. So if the patient has an IPI more than 3, regardless of age, if the patient is young, fit, should transplant in CR1 for consolidation. And only those rare patients who will have an IPI less than 2, maybe they can be done away without a transplant in CR1. But again, this is not a very strong data in favor of this recommendation. So coming to the hot topic, the brentuximab, which has been discussed extensively, it's an anti-CD30 antibody combined with, a protease cleavable linker to the chemotherapeutic drug monomethyl auristatin E. So when you give it, you combined it with chemotherapy, not as a single agent, because yesterday we've learned that single agent is almost practically not going to yield great responses. So this was CHOP versus, the same thing excluding the vincristine. And there was, in the Echelon 2 trial, there was a difference in the median progression-free survival. It almost more than doubled from 20.8 months to around 48 months. So definitely there is a signal in favor of using brentuximab as an upfront therapy in these patients. And these tumors are universally going to express CD30. So that's never going to be a question. And also, surprisingly, there was an overall survival, favoring the ACHP arm rather than the CHOP arm. The median OS was not reached in both arms, but there's a hazard ratio of 0.66 favoring the brentuximab arm. So just, to summarize now, these are the last 2 minutes I'll take. The induction regimen, now the preferred time in today's day and age should be a brentuximab based therapy if it is available. If not, then we have an option of CHOP or CHOP etoposide. Already mentioned when would you consider CHOP, when to consider etoposide. And infusional regimens have usually not shown to be better than, CHOP. They have increased toxicity rather than, increased efficacy. Consolidation, again, if IPI is more than 3 and age is more than 40, I would want to consolidate. If there's a relapse of the disease, then you first need to determine, like in all lymphomas, if it's a chemosensitive disease or a chemo-resistant disease or refractory disease. So chemosensitive, you try any one of these salvage regimens followed by a autologous transplantation. And if there's a chemo-resistant disease, we are looking more at novel agents or participation in trials, because this is quite a gray zone. And the novel agents for ALK positive disease, you at least got ALK inhibitors, but the major issue is with the ALK negative ones, where there's, just very few agents available. So coming again to the induction, it doesn't differ much for the ALK negative ALCL as well. It still remains the same. And the consolidation with transplant just keeps increasing. Chemosensitive and resistant diseases treated on similar lines. Now coming to the primary cutaneous lymphoma. So how do these lymphomas present? So cutaneous lymphomas, before we call them cutaneous, rule out systemic disease, and cutaneous usually involves the trunk and the head, face, and neck. Usually it's a unifocal disease. At times it is multifocal but confined to the same area. So you still have an option of a complete surgical excision or a radiotherapy, because the site is still amenable to be in the same site. Again, brentuximab has been approved in this space. There are options of also giving methotrexate and bexarotene, as Dr. M.B. Agarwal sir said. But this is again an option for a multifocal disease, not for a unifocal, where the best treatment remains, complete surgical excision. If the disease recurs, which it usually does, we can again apply the same principles. If it's recurring in the same, field, small area, still amenable to radiotherapy, we may consider that. But I would be a little more keen on trying on brentuximab in this space. And for the breast implant associated ALCL, excellent outcomes. Most of the times it's a localized disease, just presents with, little breast tenderness, pain, increase in size of the breast, some fluid accumulation, serositis. So then again, the treatment is breast implant explantation with a total capsulectomy. But it's important to remember that the rate of recurrence in the contralateral breast is really very high. So they recommend that there's a contralateral implant which is uninvolved, it should still be removed. But if in rare cases it presents with a systemic disease, you treat it in the same way. But obviously, sometimes if it's truly systemic and it's not amenable to therapy locally, you might use chemotherapy on similar lines at the systemic ALCL. So the options for relapsed refractory disease here, you again always have to subclassify if the patient is an eligible population for transplant or not. Options remain the same. The same drugs have been used in different settings and different sequences. But brentuximab vedotin, if the patient is not exposed to that upfront, definitely for a transplant eligible patient, including it as the bridging therapy would be recommended. Again, for a non-transplant eligible, I would still consider using the drug because it's fairly well tolerated. It's just that it will not be able to be consolidated. And in cases of recurrent relapses, obviously there is allogenic stem cell transplant, which still has a role, considering with the caveat that there is almost 1 in 5 non-relapse mortality. So these are just the drugs. There is some upcoming data with JAK inhibitors, because as I said, the JAK-STAT pathway is the one which is involved. And predominantly the ones with ALK inhibitors would play a role in the second line therapy of ALK positive ALCLs. With this, I'll conclude and I'd like be open for questions. Thank you.
Hello, sir. Sir, if there is a patient with primary progressive disease on CHOP and having CNS involvement, what would you prefer?
Again, CNS involvement in anaplastic large cell lymphoma, fortunately, is quite rare.
You have a patient like that, that's why. He's not affording brentuximab. Do you think brentuximab would be effective in CNS involvement?
I don't think brentuximab has a great CNS penetration. I would definitely like to treat the systemic disease using a brentuximab-based approach, and then treat as with any other lymphoma with with a CNS disease, maybe probably with a cytosar-based approach or triple ITs in the meantime to clear off.
Yeah, so we have
It's a really
started on,
rare presentation. I
we have
would say.
started on triple ITs and CSF disease have cleared, and we have started him on crizotinib. So what do you think? Should we add a chemotherapy backbone to this to increase the response?
So he's a young male, right?
Yeah, he's 30-year-old male. We could get crizotinib on a compassionate basis, but he couldn't afford brentuximab.
He could afford now.
No,
he couldn't.
He couldn't.
Okay, so probably like he's not responsive to CHOP.
He progressed on CHOP.
So any salvage therapy that has been tried other than brentuximab?
No.
So I would recommend that with the CNS-based approach and then consolidating with the transplant if he responds to the salvage therapy. That should.
He was actually PS3 when he presented to us, so we had to start him on crizotinib, and we have actually added a vinblastine backbone for time being. So do you have any other options?
No, I would just recommend that if his fitness improves, probably consolidate with the transplant and a salvage regimen to get him into a CR, or else it looks grim.
Thank you.
If at all you get an option of choosing another ALK inhibitor, you could probably consider alectinib or lorlatinib. They penetrate the CNS way better. Very good CNS efficacy.